The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have Dr. Will Chapman here to review the management of all things appendix.
It's great to be here, Paul. Thanks so much for having me.
Dr. Chapman is a colon and rectal surgeon at Washington University in St. Louis. My name is Paul Kepper, and I'm a general surgery resident and will be your host for this episode. Today, we will be discussing appendiceal pathology, and acute appendicitis is one of the most common general surgery consults that you will receive. Let's dive right into a case scenario to help guide our discussion.
Great. Sounds good.
A 32-year-old female presents to the ED with 12 hours of right lower quadrant abdominal pain. What are some of the things you would like to know about her history and physical, and is there any additional imaging or lab work that you would like?
Yeah, Paul, this is a great case. And, anytime we're talking about the appendix, it's easy to get sucked into some of the obvious things that as surgeons we always jump to. But in young folks, especially young women, you got to keep a couple things in mind. So first and foremost, I remind everybody to keep the differential broad and don't jump to conclusions. So we've got, a young woman with right lower quadrant pain. There's all kind of stuff we need to think about. So from a GI standpoint, I want to know what are any associated symptoms like anorexia, changes in the character or location of the pain, duration. But also I'm interested to know, some unique things like, are they having fevers or not? What's their menstrual history like? Are they sexually active, or do they have, has the ER gotten a pregnancy test or not? These are all really important to keep in mind while you're looking at these folks.
And you had mentioned pain. Anything specific that might point you towards appendiceal pathology? And is there really a reliable character for this pain, or what are some instances where that pain may be a little bit atypical?
Yeah, certainly in cases where you've got appendicitis or inflammation of the appendix, we look for pain in the right lower quadrant, and that classic story of periumbilical pain that's migrated to a more focal or pinpoint location in the right lower quadrant is something we see quite frequently, but it's certainly not always there, and you certainly can't hang your hat on it.
Yep. So we mentioned that focal point. It's classically referred to as McBurney's point. And this is about 1/3 the distance from the anterior superior iliac spine to the umbilicus. Mm-hmm. It is important to keep in mind that with variant locations of the appendiceal tip, you may not see pain in this sort of pathognomonic location, especially if you have a retrocecal or pelvic appendix.
Yeah, and it's also important in different disease states too, or folks with different comorbidities, they may mask their pain or otherwise not express pain. So, if you have a patient who's on steroids for some reason, or is otherwise immunosuppressed, you may get a very different presentation, even in the setting of a quote unquote classic acute appendicitis.
Yep. Speaking of classic presentations of acute appendicitis, there are some pretty stereotypical maneuvers. I was wondering if you could take us through a couple of those.
Yeah, for sure. So, all of these maneuvers are aimed at perturbing the appendix in its usual location, sitting just anterior to the psoas muscle on the right side. So, one is the obturator maneuver, wherein you flex the right knee and internally rotate the right leg. Another is where you extend the right leg at the hip. This really puts that psoas on stretch and can cause an inflamed appendix to rub against the muscle as it moves, reproducing pain in the right lower quadrant. And then the last one is the Rovsing sign, wherein an examiner puts pressure on the left lower quadrant of the abdomen and reproduces the pain in the right side. It's a rough test for referred pain from an inflamed appendix.
Perfect. And then what would be some typical laboratory findings that you would expect on your patient with some appendiceal pain?
Yeah, so, in the setting of an appendicitis, obviously we're looking for a leukocytosis or an elevated white blood cell count. In somebody who's had significant anorexia or vomiting, you can also see metabolic abnormalities like an alkalosis or signs of dehydration, like an elevated creatinine. Going back to the original presentation, when you have a young woman, you also want to rule out potential other causes of pelvic or right lower quadrant pain. So getting something like a pregnancy test, a UA even to look for signs of a UTI are also important.
Yep. And in today's day and age, with really ubiquitous imaging, it's not uncommon for these folks to already have a CT scan. And most typically, what you would expect to see on imaging is some appendiceal distension, say greater than 6 millimeters. You may or may not see a stone. You'll see some periappendiceal fat stranding. You'll usually see no gas there within the appendix. And in cases of perforation, you might see a phlegmon or an abscess. But there are some situations where a CT scan isn't appropriate. And I was wondering if you could walk us through some situations where you want to avoid a CT scan and what other imaging modalities you might employ.
Yeah, certainly. I mean, in the era before CT was so readily available, a lot of folks, adults and children, were getting ultrasounds to try and better diagnose appendicitis. In the adult world, we really do rely on CT scan for the most part, but certainly in kids and in children's hospitals, ultrasound is very widely used to diagnose appendicitis. And in general, you're looking for the same findings: a dilated appendix greater than 6 millimeters in size, lack of compressibility, or the identification of a fecalith. There are some unique circumstances in which we use MRI. As a colorectal surgeon who deals with peritoneal disease, I do get a number of referrals for folks that have appendiceal masses. And depending on their presentation, I will sometimes get an abdominal and pelvis MRI to try and better characterize a tumor. But in general, if you're dealing with someone in the emergency department and you're working up an acute appendicitis in your differential, MRI is usually not a test that we would use.
Yeah, fantastic. So our 32-year-old patient, she actually has a leukocytosis with a white count of 14,000. Her pregnancy test is negative. She is a little bit dehydrated. Her creatinine is up to 1.4 from a baseline of 0.9. What would be your next steps in the management of this patient?
Well, obviously, once we've made a near certain diagnosis of acute appendicitis, you then got to talk to the patient about treatment. And really, in today's day and age, we focus that conversation around two options. One is the surgical removal or resection of the appendix. That's the classic therapy for acute appendicitis. But certainly, there's also a role for definitive antibiotic management in the right or appropriate patient. So let's talk about surgery first. In folks who are good surgical candidates, this is typically done laparoscopically, usually through 3 incisions. Takes about 45 minutes. And the critical anatomy we're looking for there is to get in, identify the right colon and the cecum, make sure that we then identify the base of the appendix and ensure that that's healthy and viable. We're also looking for any abscesses or other signs of broader inflammation that may be affecting the small bowel or the iliac artery, which tends to run right underneath the location of the appendix in the right lower quadrant.
Yeah, it's always important, even before starting to prepare for an operative procedure, to give these patients IV fluids to resuscitate them as well, especially if there's been evidence of emesis or evidence of dehydration on the labs. And then you can, of course, start with antibiotics, even if you are planning for surgery, obviously with the goal of covering enteric flora. You mentioned the port sites. Typically, you'll have a 10 millimeter port at the umbilicus and then 2 5 millimeter ports, one in the left lower quadrant and one in the suprapubic midline just above the bladder. Typically, the operation proceeds with division of the adhesions of the appendix, elevating the appendix, dividing the mesoappendix either with an energy device or some staples, and then stapling across the base of the appendix and then removing the specimen. Of course, if there is concern for perforation or there's a large amount of succus there around the cecum, do consider irrigation, and based off of surgeon preference, sometimes even a drain can be placed. What do you, in your experience, have you found to be some of the main complications of surgical repairs, and how do you typically address them?
In general, it's a pretty well-tolerated procedure and relatively low risk. I think most of the complications arise when folks have an appendix that has ruptured or is near rupture at the time of surgery, and you get some contamination in the field. That can often lead to abscess formation. And just like you mentioned, some people leave drains in that setting, but the data is very mixed on that. And even in people that have perforations where a drain has been left, they can still develop abscesses. So it's certainly not a definitive prevention technique. The other thing that we worry about is dehiscence or breaking apart of that staple line at the base of the appendix. If you have inflammation that goes all the way to the base of the appendix, sometimes you have to take a little bit of cecum in order to get back to good healthy tissue and prevent a blowout or dehiscence of your transection line. Obviously, when you do that, you just got to be careful about the ileocecal valve.
And then a patient presents maybe 2 weeks, 3 weeks after surgery with some recurrent right lower quadrant pain. You get repeat imaging and you find a 5 centimeter rim enhancing fluid collection there in the right lower quadrant. How would you typically treat that?
All depends on the size of the abscess and the amount of their symptoms. In general, I would try to start antibiotics, avoid any sort of reoperative intervention. So if they need a drain, you can get a drain in there. Oftentimes these abscesses are small, and antibiotics, even for a more prolonged course, is sufficient to resolve that.
Okay. And then you had mentioned the possibility of antibiotics alone. Can you maybe discuss your decision-making for who would be an appropriate candidate for non-operative management of acute appendicitis?
Yeah. I think you have to first and foremost think about the patients that are not good candidates for that. So in my opinion, people who are sick or have significant medical comorbidities who would not be able to tolerate smoldering appendicitis or perforated appendix are in general people who are not good candidates for antibiotic therapy. You want to be thinking that if the antibiotics do not resolve the problem, is this person going to be able to tolerate the prolonged illness? And so older, frail individuals or people with immunosuppression or lots of medical comorbidities are not candidates in my eye. Additionally, if someone has a fecalith, I think it's very unlikely that antibiotics are going to provide durable resolution of their appendicitis. And in those cases, I definitively offer surgery. Other than that, I think it's worth a discussion. I will say in my practice, most of my patients opt for surgical intervention because of concern for recurrence of appendicitis in the future.
Yeah, and that concern is very valid. There is the APAC trial that followed patients that were treated with antibiotics alone versus laparoscopic appendectomy. Actually showed that at 5 years, 39.1% of those with antibiotics alone went on for recurrence. And so that is a pretty significant recurrence rate for those that aren't treated with surgery. So you send off your specimen for pathology and you get the report about a week later that said that there is a 1.5 centimeter neuroendocrine tumor at the tip of the appendix. How would you manage this patient?
Yeah, now that we're getting into these sort of appendiceal neoplasia, we're falling into a bit of a black pit. But I think there's been a lot written about this, and it can certainly get confusing. There are a few pearls that I think are really key to hold on to. So, I would say that neuroendocrine tumors are some of the most difficult to manage, or at least to think about. Let's start with something a little bit easier. So if it comes back with an adenocarcinoma, an invasive cancer of the appendix, the person needs a right hemicolectomy. Doesn't matter the size, doesn't matter your margins, right hemicolectomy. If the person has a mucinous neoplasm, in other words, not an invasive cancer, but a neoplastic process, as long as your margin is negative and there's no evidence of a perforation, your treatment's done. Now, if at the time of your appendectomy, you see mucin in the abdomen or there's concern for perforation on the pathology, that person probably needs to at least see someone who specializes in peritoneal disease or a colorectal surgeon to talk about the risks and benefits and what might be needed. And then for neuroendocrine tumor, there are some guidelines related to this. In general, if the size of the neuroendocrine tumor is less than a centimeter and your margin was negative, that is considered, the appendectomy alone is considered definitive therapy. If it's greater than 2 centimeters, most guidelines recommend a completion hemicolectomy for appropriate staging of that neuroendocrine tumor. Though, again, I think this all comes with a grain of salt. You really got to talk to the patient. If it's a low-grade tumor and they're an older individual, there's probably not a whole lot of benefit from taking out the right colon.
Well, thank you, Dr. Chapman, for this amazing tour of appendiceal pathology today. We got through a ton of great information. And as always, if you're looking to learn more, you can check out some of the literature we referenced in today's episodes in the show notes. And a full review of appendiceal pathology can be found in the Washington Manual of Surgery, Chapter 22. Thank you, everybody.
Thanks so much, Paul. It was great to be here.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.